So I'm Dr. Darryl De Vivo. I'm a professor of neurology and pediatrics at the Columbia University Irving Medical Center, located here in New York City. And I've been here now for 40 years, initially as the director of the Child Neurology Service, and then later continuing with patient care and with our clinical research program here at the medical center. Coming to understand Glut1 deficiency, I think, recalls for me some famous comments made many years ago. I'm a bit of a history buff as it relates to the history of medicine. And I recall important comments like those made by Louis Pasteur in 1854, when he was giving a lecture at the University of Lille in France. And at one point he pointed out that in the fields of observation, and he was a physician, so in the fields of observation, chance favors only the prepared mind. And I like to think that's relevant to a number of issues when we practice medicine. I think there are opportunities being presented to us every day to make significant observations, to advance the field, increase the understanding of the problem that the patient has, and ultimately to develop some understanding of how to treat the problem as such. And I think that thinking is relevant to my own personal professional experience and development, and also I think to what all physicians should be alert to. The opportunities are being presented every day, usually by the patient and the family. And our job is to listen, to think about it, to not discard it as something that doesn't make any sense to us at that moment in time. I like to think that there's no useless information. I think there is a lot of information, some of which we can't use at the moment, but at some point in the future, it might turn out to be relevant. Very much as Pasteur said, when the opportunity presents itself, we have to be prepared to take advantage of it. I myself wrestled in medical school as to whether I really wanted to go into metabolism and endocrinology or into neurology. And I finally ended up combining the both, so I had the best of both worlds. So I got very interested in neurology and the developing brain, and particularly interested in the metabolism of the developing brain. And really, until 1966, we as students of the brain were always told that the only fuel that the brain could use is glucose. And in 1966, one of the graduates from our medical school, from Columbia University Medical Center, George Cahill, having moved on to Boston and directed the Joslin Clinic for Diabetes there, wrote an extraordinary, insightful paper at that time. And basically what he said, if the brain always used glucose, no matter whether you were well-fed or fasting, during the periods of fasting, you would end up depleting all of your muscle protein in order to provide enough glucose for the brain during the period that you were fasting. So he said that just can't be the case. Another example of what Pasteur had taught us in the past. You have to think it through and decide, gee, does this make sense or does it not make any sense at all? And George Cahill and his colleagues said, it doesn't make any sense. The brain must use something else under these situations of fasting. So he did, with his colleagues the next year in 1967, a critical experiment. I would have to confess maybe the Institutional Review Board might not have approved that study in 2018, but in 1967 they did approve it. And Dr. Cahill and his group fasted adults who were terribly obese for periods of 30 to 60 days or longer on their clinical research unit, and then they looked at the extraction of metabolites as the blood flowed through the brain from the arterial side to the venous side, and they looked at what was being extracted. And lo and behold, they proved beyond a shadow of a doubt that during the prolonged fasting, the amount of glucose being used to account for the oxygen consumption had dropped from 100% to 29%. And the ketone bodies, beta-hydroxybutyrate and acetoacetate, now accounted for about 70% of the oxygen being consumed. So with one brilliant series of studies, Cahill and his group demonstrated that the textbooks of neurochemistry had been wrong for all of the millennia prior to that point in time. And he showed beyond a shadow of a doubt that during fasting at least, and probably even during the fed state, the brain has the capacity to take up glucose or ketone bodies as metabolic fuel to support the energy demands of the brain, not only during development, but also after the brain has fully developed into adolescence and into adulthood as such. And that was just about the point when I was at the National Institutes of Health and finishing my training, which I completed at Washington University. So I wrote my very first R01 grant for the National Institutes of Health, and it was titled Seizures, Ketosis, and Cerebral Metabolism. And we were fortunate to get funded on that occasion, and so for the next several years, I spent my time studying conditions related to blood glucose, hypoglycemia, hyperglycemia, and also conditions associated with ketosis. And we also asked the fundamental question as to how the ketogenic diet actually works to control seizures. What is the anticonvulsant mechanism of the ketogenic diet? And so that was our beginning of our study, and you know, ketogenic diet had been used since 1921, both at the Mayo Clinic, where there was a publication, and also at our institution here in 1921. There were 2 papers published showing that a ketogenic diet could control seizures, and the reason for the diet was to try to simulate the concept of fasting, and it was known even from biblical times that if an epileptic patient were to fast for a period of time, they would have cessation of their seizures for the time they fasted. But one could not fast indefinitely. So they crafted a diet that made ketone bodies, a high-fat diet, the ketogenic diet, to simulate the benefits of fasting and the control of the epileptic condition. So we were intrigued by that. We were also intrigued by the work by George Cahill and his colleagues. And so we set about over the next decade to understand how ketone body utilization by the brain improved the brain's metabolic status so that seizures were less likely to occur. And we developed an animal model and made a series of observations looking at a variety of different mechanisms that would ultimately help us in understanding the mechanism of action of the ketogenic diet. And it's clearly multifactorial. There are a number of metabolic activities going on in the brain when you're ketotic that lend themselves to improving seizure control as such. So that was kind of some of the backdrop to me when I first came upon the patient, Joseph Ruggiero, and his family in 1989. Joseph, when I saw him, was now 7.5 months old. He was born in January of that year, and I saw him in August, mid-August, August 14th, I remember it very clearly. And he had been referred to me by a very good, 2 good child neurologists in Westchester County, one of whom actually had trained with us, Robert Wolf, and the other was his later partner at Westchester, Ronald Jacobson. And they had come upon Joseph when he first started having myoclonic seizures at age 2 months. And in the course of evaluating him, they did a series of lumbar punctures, 3 in number. They did one in March of that year, and what they found was the blood glucose was normal, but the spinal fluid glucose, instead of being about 2/3 of the blood glucose, was less than 1/3. So roughly the blood glucose was like 100, and the spinal fluid glucose was about 20 or so. So much lower than we would expect. Joey continued to have seizures, and Dr. Jacobson repeated the spinal tap. I think initially he did it to rule out the possibility of infection or meningitis that might happen in a newborn baby as such. And the spinal fluid otherwise was quite normal. He repeated a second spinal tap about 2 months later in May. And again, he found that the blood glucose was normal, and the spinal fluid glucose was again disproportionately low. And it was about at that time that he called me for advice as to what this might mean. And I said to him, well, what was the lactic acid in the spinal fluid? And he said, well, we didn't measure that. So I said, well, maybe if you do another one, then you might measure lactic acid in the spinal fluid as well, because in those days, and even now, we were very interested in mitochondrial diseases, and we knew that the spinal fluid lactic acid was elevated, and occasionally the spinal fluid glucose could be low, but not nearly as low as we were seeing with Joey, this particular patient. So Dr. Jacobson repeated the third spinal tap in July, and he found that the blood glucose again was around 100, and the CSF glucose was around 20, and the CSF lactate was 3.7, which is an elevated value. And so we assume, well, maybe he does have a mitochondrial disease, but we don't understand why his CSF glucose is so low. So he came to see me in referral from Dr. Jacobson in August 14th of 1989, when he was 7.5 months. And at that point, he had slowed down in his early neurological growth and development. He was continuing to have many, many myoclonic seizures each and every day. He had had a gradual deceleration of his head growth. So initially it had been at the 50th percentile, and now it was approaching the 3rd percentile over this period of 6 or 7 months or so. So being, I guess, a compulsive neurologist, I asked if we could repeat a 4th lumbar puncture and measure some other metabolites in the CSF, including the glucose and the lactate. So we did do that. 2 days later, we admitted him to the hospital, and we found again the blood glucose was normal, the CSF glucose was low, but our CSF lactate value was very low. It was 0.31. So I said, that's puzzling. So I called up the laboratory that had done the original test and to confirm the result of the lactic acid. They said, yes, doctor, we did do that, and it was 3.7 milligrams per deciliter. And I said, I'm sorry, what were the units? And they said 3.7 milligrams per deciliter. I said, oh, well, that explains it, because we measure in millimoles per liter, and there's about a factor of 10 difference between the two. So 3.7 milligrams per deciliter is equivalent to about 0.31 millimoles per liter, the exact value we got. So as a result of that, we now had concordance in the 3rd and 4th spinal tap. Both CSF lactate values were low. But Joey had never been hypoglycemic. So in the absence of hypoglycemia and in the absence of infection in the nervous system, anything else that might disturb these metabolites, I concluded, and I brought his chart with me actually. Here, this is Joey's chart. And I remember sitting with the family at that time and pointing out to them that there's only one way we can really explain this, and that there must be a problem for sugar getting from the blood into the brain. And I drew this diagram for them at the time when we were sitting there in the hospital, actually. And I said, look, we've done all these tests. We've now had 4 lumbar punctures. And on every occasion, the blood glucose was normal. The CSF glucose was very low, and I assume the brain glucose is also very low. And now we know that the CSF lactate, which I originally thought was increased, as shown here on the diagram, is in fact decreased, and we've now replicated that. So on both occasions, the CSF glucose was low. And the only way I can explain this, and again, this comes back to the quote from Louis Pasteur, that chance favors only the prepared mind. So I said the only way we could explain this is that there's a problem for the glucose to pass from the blood across the blood-brain barrier into the brain and into the spinal fluid. So our hypothesis at that time, this is now 2 or 3 days later, was that there is a block, probably a genetically determined block, in the transport of glucose across the blood-brain barrier. Now, mind you, in 1985, Dr. Michael Meckler had discovered the Glut1 protein. That was the beginning of the story of transporters that move substances like glucose from one area to another across a membrane that is filled with a lot of lipid. And so glucose is water soluble, and it won't naturally pass through a membrane that's filled with lipid. It's like mixing olive and water and oil together. So there has to be some mechanism to carry the water-soluble glucose molecule across the lipid membrane. And Mike Meckler discovered the Gluten One Transporter, which was made by a gene on chromosome 1. And he showed that this was one of a family of proteins that are responsible to transport substances across membranes, like the blood-brain barrier as such. So I had the knowledge of Mike Meckler's work in the transport of glucose, and so we assumed that there was a mutation in the Glut1 gene. So I reached out and partnered with a doctor at Harvard Medical School at the time, Dr. Morris Birnbaum, and said, I think there's a mutation in the Glut1 gene, and we should make an effort to try to find that. And this was, of course, back in the 1990s, so that's like 100 years ago compared to where we are now in molecular genetics. So it wasn't something we could run into the lab and next week have done the experiment. So we spent years working on this experiment to try to determine whether we could characterize a mutation in the Glut1 gene. And finally we did, not only in Joseph, but in a second patient that we had seen right after we presented Joseph at the Child Neurology Society in 1990. And so Joseph and that second patient served as the paper that we published in the New England Journal of Medicine in 1991. And then after that we saw 2 more patients, the third and the fourth patient. And those 4 patients, we demonstrated a disease-causing mutation, in each case a different kind of mutation, in the Glut1 gene, and we published it in Nature Genetics, a very good journal, in 1998. And I think at that point we established Glut1 deficiency as a real disease, a genetic disease, transmitted as an autosomal dominant trait almost always, although later we found some families from the Middle East who were consanguineous, and they presented with autosomal recessive transmission of Glut1 deficiency as such. But we kind of firmly put it on the map as one of the rare diseases. So the reality is that myself and others like me, particularly in child neurology, have been spending our life studying rare diseases long before we called them rare diseases as such. And I might remind you that a rare disease was originally defined in 1983 and signed into law by President Reagan as an orphan condition that affected 200,000 or less people in the United States. And we now know that there are at least 7,000 rare diseases. Of the 10,000 human diseases we know about, 7,000 are defined as rare diseases, and they affect 28 to 30 million people in the United States in aggregate. So about 10% of the population in the United States have a family member who's affected with one of these many rare diseases as such. And many of these patients have neurological manifestations as part of their clinical presentation, their clinical phenotype as such. So we increasingly got introduced into this whole area of rare diseases, genetically determined conditions, and of course with the advent now of precision medicine and the emphasis on understanding our uniqueness as human individuals, because all of us have a genetic background that is unique to us and only us as such, that we've gotten very interested in studying this in greater detail and looking at it as a way to effectively find a cure ultimately for this disease. But let me go back to Joey for a minute. After we came to the idea that this could be a defect in the transport of glucose, we suggested that he go on a ketogenic diet. And I remember talking with Mom and Dad, and they said, well, you know, nothing else has worked, and what do you think? And I said, well, with our experience with other patients with epilepsy, when we put them on a ketogenic diet and they respond, they usually respond within 72 to 96 hours. So I'm hoping that would be the case here. And later, Joey's mother, Angela, contacted me about the third day and said, Dr. De Vivo, we started the ketogenic diet, we went home from the hospital, and now the third day, and he's had no seizures at all, and it's the first time since he was 2 months old that he's had no seizures at all. So that was another little piece to the puzzle that our thinking was probably correct. That is, not enough glucose was getting into the brain, and therefore the additional need for metabolic fuel was being provided by the ketone bodies that got in through a different transport mechanism. And therefore, we had a mechanism to treat Joey and subsequently other patients with Glut1 deficiency. And the ketogenic diet remains the standard of care in the management of these patients. But we hope later to increase our recognition of these patients very early in life as they first present, usually within the first 6 months of life, most commonly certainly within the first year of life. Alert physicians that there is a presentation that is pretty typical for these patients. Most of the time it's a seizure of one kind or another in an otherwise normal appearing infant who's developing, or alternative, they have very peculiar eye movements, which we ourselves mistakenly initially called opsoclonus, a funny chaotic movement of the eyes. But later we carefully studied these eye movement abnormalities and concluded it was like opsoclonus but different. And we have since labeled it eye-head abnormalities or aberrant gaze saccades. And we think that is essentially diagnostic of Glut1 deficiency. So if we can teach all of the primary care physicians and the pediatricians, if you have an infant who looks healthy, is developing normally, and has a seizure or funny eye movements or other peculiar paroxysmal events, think Glut1 deficiency among other things and consider doing a spinal tap. And if the CSF glucose is low, and the CSF lactate is low, then I would say you have about a 2/3 chance of being right if you say this is Glut1 deficiency. There are some other kind of disease lookalikes with Glut1, so that's the other third. They have low CSF glucose, low CSF lactate. But they don't have an abnormal uptake of glucose by the red blood cell, which is an assay system that we also developed. And we don't find a mutation in the Glut1 disease. But in the 2/3 of patients, we do find a disease-causing mutation in the Glut1 disease. And at least we can start treating the infant at the presentation of the first clinical event. And ultimately, we hope to move that back to newborn screening, because all of these rare diseases that we're talking about, and I remind you of the 7,000, we only have effective FDA-approved treatment for 350 of them, 5% of the 7,000 do we have effective treatment as such. But if we can identify them in the newborn period when they're normal and treat them proactively rather than reacting to their symptoms when they present later in infancy or childhood, then we have a much better chance of protecting that developing brain from the beginning. So we have to keep working and developing a method where we can identify Glut1 deficiency in the newborn period, or even earlier than that, by testing the parents, although most of the time the parents do not carry the mutation that causes the Glut1 deficiency in their child. I always like to reflect on some of my earlier experiences seeing patients, and particularly if it's a patient like Joseph, who turns out to be the very first example of a new condition, a new disease. And there are a couple of points I like to make, particularly with our residents in training. I always emphasize to them, don't discard any information that doesn't make sense to you. It probably doesn't make sense to you because you're not prepared to truly understand it. And so I know in my own experience, although I can't recall specifically examples, that we got CSF glucose values that were lower than they should have been, but we would say, well, it was probably a laboratory error or something of that nature. And sometimes you're throwing away a valuable observation that if you force yourself to think about it, you'll finally come to a full understanding of why that value was what it was, in this case, a low CSF glucose, and it led you to a series of thoughts that were otherwise unanticipated as such. And the other point I like to point out to the residents is listen to the patient and listen to the family, because we are so fortunate to be in a profession where every day is a learning experience. We're students for the rest of our life. We're going to be learning and learning and learning. And we learn from our patients and we learn from the families. They're living with this disease. They have it or they're living with it. And they're trying to teach us something. So pay attention to it, because they are going to end up educating you about their condition. And I frequently, when Angela or Nunzio might call me, and I would be listening to them for a period of time, and then Angela said, "Are you still there, Dr. De Vivo?" And I said, "Yes, I'm listening to you. I'm learning from you," as such, which I meant in the most sincere way, that I learned a lot from Joey and from Angela and from Nunzio and from large numbers of patients that I followed over the years. The third point is that Joseph was the first case. And then the second child was presented to me. So, to be a little humorous for a moment, I reported Joseph as a single case report as an abstract at the John Neurology meetings in 1990. And then at that meeting, I met the doctor who had the second patient, and I saw the second patient, and we wrote a report of the two patients in the New England Journal of Medicine as such. And it reminds me of an old joke that when you see the first remarkable case, you say, this is the extraordinary case report, and you present it as such. And when you see the second patient, you say, in my series of patients. And then when you see the third patient, you can turn around and say, in case after case after case, this turns out to be the case. So I would say in this situation, in case after case after case, the CSF glucose is always low in these patients who have Glut1 deficiency. But as you accumulate an increasing number of patients, and we see this now more and more, particularly with newborn screening, and I'd use one example, Pompe disease, that is a different genetically determined disease, autosomal recessive, affects also sugar, glycogen metabolism. So it's acid maltase deficiency, but in infancy it's called Pompe disease. And we always thought Pompe disease presented in infancy and was universally fatal over the first several months of life as such. But we started doing newborn screening because we had developed a treatment for Pompe disease now. So once you have a treatment, you have a good argument as to why you should do newborn screening as such. And when you do newborn screening, now you start seeing everybody who has that mutation while they're healthy, and then you follow them and see what the clinical picture is like. And what we saw in Pompe disease is only about half of the patients with the mutation had Pompe disease as we had come to understand it, and the others presented later, as early as 1 year of age or as late as 60 years of age, and yet they seemingly had the same mutation as such. So immediately the spectrum of Pompe disease started to expand as we saw more and more cases, and then increasingly were able to do newborn screening and see more and more patients from the beginning and follow them through their natural history. And so that's what's happening in Glut1 deficiency. So we reported one case in 1990, 2 cases in 1991, 4 cases with mutations in 1998. And now we know of hundreds of cases. And we recently reported on 14 patients who I'd had the privilege of following for more than 20 years. So we could look at their clinical presentation over time. And what we found is that in infancy, their presentation was mainly epilepsy. So it was an epileptic phenotype. But if we continued to follow them, like I have with Joseph now for nearly 30 years, we found that in late childhood and early adolescence, the seizures largely abated, went away largely on their own or with treatment, but now they started having abnormalities of movement that were either paroxysmal in nature, that come on, interfere with their ability to walk or to stand up correctly or move or whatever, to continuous. So they would have continual dystonia or ataxia or chorioathetosis and so forth. So this same disease that looked like an epileptic condition in infancy now had morphed into a disorder of movement in late childhood and early adolescence. And so increasingly, we're coming to see that the spectrum of clinical presentation of Glut1 deficiency in part is age determined and also related to regions of the brain that are developing at different points postnatally. And so we have seizures early on, we have disorders of movement later on, and we have a variety of other abnormalities. We have patients who have headaches that are essentially indistinguishable from migraine headaches. I talked about the funny eye movements that we see now, which we think might be diagnostic. I've never seen it in any other condition thus far. So for the moment, I think of it as essentially diagnostic of Glut1 deficiency, if you recognize. We have periodic paralysis. We have episodes where they have emotional, what I call meltdowns, or paroxysmal dysthymia or dysphoria as such, and all sorts of different kinds of seizures, intermittent difficulties in maintaining conscious awareness and thought processes. So a variety of disorders that we've come to recognize historically in neurology, but have been called other things in the past. For example, we have something called dystonia 18 that was originally described by Dr. James Lance in 1977. And we've come to realize that dystonia 18 and dystonia 9 turn out to be variations of Glut1 deficiency, what we call allelic variants of Glut1 deficiency. So if you look to find the genetic cause of dystonia 18, you'll find that it's a mutation in the Glut1 gene as such. So the spectrum has become quite wide and is embracing a lot of clinical phenomena that we have seen in child neurology over the years, including such things as transient weakness of one side, transient hemiplegia of childhood, for example. We now know that some of those patients, in fact, have Glut1 deficiency. So we have to spread the net wide diagnostically as we come upon these different variations. And this is so important in continuing to carry out studies of the natural history of these rare diseases. We're talking specifically about Glut1 deficiency, but what I'm talking about applies equally well to hundreds of other rare diseases as well. And everybody needs to be involved. I mean, as I said, I came prepared to think about the problem, not that I did my homework thinking I would see Joey at some point in the future, but I was learning about a lot of different things, and it turns out that information was very relevant to allow me to think through the problem that I was facing when I first met Joey as such. But also, parents have learned about these cases, and they understand Angela and Nunzio as Joseph's parents know Joseph in a way that I don't know Joseph. So I'm learning from them how they see Joseph. And also, I'm interested in following Joseph, as I've had the privilege to do now for nearly 30 years, as he gets into adulthood, to see whether there are some new issues that are going to emerge as he's an older child. Are there going to be other problems that he might have that we've thought about in the context of other issues but never related them to Glut1 deficiency as such? So it's a continuing learning process as we follow the patients. And I must say, since I guess when you get old you have the right to say certain things, I'm a little distressed about the changing characteristics in medicine, because the younger house staff are so busy, forced to do things so quickly, allowed to spend only a few minutes with their patients, where I've had the privilege of spending hours each time with my patients, because I want to learn everything I can from them and make all the observations I possibly can. If I had only 5 minutes or 15 minutes with Joseph, I'm sure I would have made far fewer significant observations as such. And also I've had the privilege of following up for a very long period of time. And all of this represents aggregate knowledge. So this is an accumulation of information which allows me to flesh out a more complete understanding of Glut1 deficiency throughout the whole life cycle. I think the biggest area of need in research, as is true, I think, for most of these diseases that we're talking about, is one, to have as complete an understanding of the natural history of the condition as possible. Number two, as complete an understanding of what I call the pathophysiology of the process. So we have the clinical presentation. I, as a physician, see the patient, talk with the family, talk with the patient, try to get a good understanding of clinically what is wrong with the patient. And then we have the wonderful advances now in precision medicine, so we can find the gene that, when mutated, causes this clinical presentation. But then we have this whole area in between, from the gene to the phenotype, which I call the pathophysiology. So what is actually happening in the organs that are affected by the genetic mutation? And in this case, specifically in the brain. What is going on in the brain? And the more we understand about the pathophysiology, we can think about the consequences upstream in metabolic pathways and downstream in metabolic pathways. And as we think about that, we can start thinking of alternative therapeutic approaches to the problem. Obviously, the ideal thing is to go in and fix the gene, repair the gene, or put in a new gene. And nowadays we have something emerging, human gene therapy, oftentimes using an adeno-associated virus as the vector to carry a good Glut1 gene into Joseph's cells and into Joseph's brain cells. So it sets up housekeeping in his brain cells and makes good Glut1 protein. And so basically we fix the problem by reintroducing a new gene, transferring a new gene into the cells where he has a mutated gene as such. But some of that is occurring now. We're working on a mouse model for Glut1 deficiency. We've cured the mice, and we're pleased about that. But in that process of studying the mice, we came upon the fact that when you don't have enough glucose getting into the brain of the developing brain, there are other consequences. For example, the blood vessels need glucose to develop. And when there isn't enough glucose getting into the brain, and the Glut1 is also deficient in the blood vessels, now you have a setup where the blood vessels cannot proliferate and make bigger networks of capillaries, small blood vessels, that are so important to nourish the growing brain as such. So now our focus is also on the blood vessels in the brain that are developing, which are underdeveloped because of the Gluten Transporter and not enough glucose in the brain in order to nourish the blood vessels and allow them to grow and to proliferate and to make bigger networks of cerebral capillaries as such. So all of that is new information, and we have to act upon that. We have to develop ways of intervening as soon as possible to prevent that delay in blood vessel development in the developing brain, which then brings us to newborn screening. I think ultimately, as physicians, I want to be a proactive physician, not a reactive physician. Historically, I and my colleagues have reacted to the patient's symptoms. And for some of these diseases, that's later than we want to be, because we find it's easier to prevent the onset of the symptoms than to rescue the patient from the symptoms, what I call rescue the clinical phenotype. So as proactive physicians, we're looking at the genes in the newborn screening study, and we're saying, oh my goodness, this patient has a disease-causing mutation in the Glut1 gene, has just been born and looks like a perfect baby. But we know sometime in the next weeks or months, things are going to start happening. There'll be some seizures, there'll be some funny eye movements, there'll be some delays in motor development, there'll be deceleration at the rate at which the head is growing, reflecting deceleration of brain growth as such. And at that point, it's getting later and later and more difficult for us to go back and restore that developing brain to being normal as such. So you ask me, when do we want to get involved and what do we want to do next? We want to increase alertness, public awareness, that this disease is genetically determined, it presents in infancy and early childhood. We have to recognize it immediately for what it is, and we have to try to move back and identify the newborn healthy baby who is at risk for developing these symptoms at a later date, and then ultimately have definitive treatment like gene therapy, for example, so that we can treat the healthy newborn before they become clinically symptomatic and allow them to develop perfectly normally as such. That all takes a lot of time. Unfortunately, it takes money. As we go from little studies in the laboratory that may cost thousands of dollars to do, ultimately to complex clinical trials which cost millions of dollars to do, and gene therapy which may take 5 or 10 years to do and many millions of dollars to do. But hopefully that'll all get truncated as we get better and better at the science related to the kind of medicine that we're now practicing. Well, one thing that I would like in informing my colleagues in the medical profession, the other doctors, in a way, I feel I've had a privileged life. I've been in an academic institution, and so I've been challenged with some of the more difficult cases. I've had the pleasure of running a laboratory successfully for many years, and my approach has really always been what later has been called translational research. So I see a patient in the office, and basically I don't understand what's wrong, and I obviously don't have any treatment for the problem, and it frustrates me, and I feel terrible about it. And so I say to the family, we'll do all we can to try to improve our understanding of the problem. And I try to take that problem into the laboratory and focus on that problem. So we do simple studies. Sometimes we do a skin biopsy on the patient, take that skin into the laboratory, grow the cells. So now we have the patient kind of in a dish, as we say, the cultured fibroblasts growing in a petri dish, and we can work on the cells. So we do cell-based studies and try to develop a cellular phenotype for the disease. And then we try to develop an animal model. Nowadays, it's a mouse model. And we develop a model for the human disease. And we try to learn as much as we can about the nature of the disease. Again, the gene that is mutated, the product of the gene, which is always a protein that is carrying out an important function in the cell, and that intervening period, what we call the pathophysiology, so which is really kind of metabolism. So in this case, Glut1 transports glucose into the brain, and then what happens to the glucose? Well, the glucose goes through metabolic pathways. It goes through glycolysis, and then it goes through oxidative phosphorylation, Krebs cycle, respiratory chain, and so forth. And we try to figure out what has happened when that isn't going on. So the cell is disadvantaged, and what happens. So I've already explained one fact, that is the blood vessels don't develop normally for similar reasons as such. So we develop the animal model, and then increasingly we go on to getting FDA approval to take our ideas into the clinical setting. And increasingly at that point we need to partner with other people who have a wider financial bandwidth than we do, so like industry. And so we're now working with a pharmaceutical company who are interested in the gene therapy for Glut1 deficiency. And they have the capacity to do things at a larger scale that we can't do. So we're delighted to partner with them, and hopefully they'll take it to the next level, and then eventually we'll take it into the clinic as a clinical trial for gene therapy for Glut1 deficiency. But we need the patients to be identified. And so the doctors who aren't living in academia like I am, who are out on the front lines, seeing everything every day, difficult task when you think about it. Who's going to walk into your door next? Maybe a Glut1 patient, maybe another patient with Pompe disease, maybe a different patient with spinal muscular atrophy, patient with infection. I mean, it's hugely complicated and demanding, so I have great respect for the primary care physicians who are out there on the front lines. And what I'm asking them to do, which is enormous, is to say, you know, when you see a patient who you think either is something you don't understand, and you need to understand it, so you refer the patient to somebody like me, or alternatively you say, I wonder if this is what they're talking about, and maybe this is a Glut1 patient. So I'll send them into a center that is better informed on the subject of Glut1 deficiency as such. And that has to happen as fast as possible in the ways that we talk about. So increasing alertness, not only in the public, but in the profession. But I don't want to downplay the public role, because the public increasingly is more informed as well. And they now ask questions that sometimes we as busy physicians don't have time to answer. They go immediately to Google. They have one patient, their child. They go to Google right away. Well, the doctor said this, and so I'm going to look up and see CSF glucose, what does that mean? And then they'll come back in the second time and start educating me. They say, well, did you see this? And I said, no, I didn't have time to look that up. And so it becomes a team effort. And so it's an expanded family working together. And I feel that very much the same way with Joseph and his family and thousands of other families that I've worked with over the years. They become extended family. I become part of their family. They become part of my family. And we're all working together for the sake of the patient. So our world is patient-centric. It's all about the patient, and all of us are trying to do something to help the patient in our own way. I'd like to point out a couple of things. One is, when I started as a neurologist, as a child neurologist, we had hardly anything we could really do to help our poor suffering patients. We listened carefully, we tried to make the diagnosis, we were terrific examiners. We could identify symptoms and signs, and we're very astute in that regard. And we would do spinal taps because we didn't really have many other things we could do. We could do some plain x-rays, a plain x-ray of the head, but we couldn't look at anything inside the head with the x-ray as such. And then we would do the best we could, making the patient comfortable and helping them live with their disability. And in that regard, as a child neurologist, I always worked with the family because the patient was part of the nuclear family and drew strength from the family, and the family also drew strength from the patient as such. So there was this interaction between the child with a disability or a disadvantage and the parents who wanted to help and work with the child to allow that child to be as productive and successful as possible under the circumstances of their disability as such. And I carry that through to the present time. But in addition now, over the last 50 years, just think of what has happened. We've gone from a specialty that simply could make a diagnosis, not always correct, I might add, but we did the best we could. And we would look at the spinal fluid and measure some things. But we had no other real diagnostic tests. But now we have CAT scan, CT scanning, and in addition now MRI scanning, and in addition to MRI scanning, functional MRI, so we can look at regions of the brain that are involved in carrying out certain functions. And now we can look at the chemicals in the brain, NMR spectroscopy, imaging as such. And now we can also do spinal taps and look at an array of metabolites in the spinal fluid that sometimes are only abnormal in the spinal fluid. So if we look in the blood and the urine, we won't find a biomarker that tells us what is wrong with the patient as such. We've increasingly found effective treatments in areas, let's say like epilepsy. We have scores of drugs and management techniques to help us in managing patients with epilepsy. But most importantly, and particularly in epilepsy, for years we treated the patients with epilepsy as though epilepsy was the disease. But I kept mentioning to my students on many occasions, epilepsy is the symptom. It's not the disease, it's the symptom. We have to figure out what the disease is that's causing the epilepsy. Enter precision medicine, looking at the genes. We have 22,000 genes in our nucleus. We have 37 genes in our mitochondrial DNA. Both are very important because when they're mutated, they cause bad human diseases. And the more we understand of the genetic basis for these diseases, the more we'll understand the pathophysiology and the gene product, which is the protein, and the function contained in that protein. And with that, we are now more intelligent in crafting therapeutic interventions that will either replace the function, replace the protein, deal with the pathophysiology, so maybe there's a different way to deal with the metabolic problem, or fix the gene as such. So in 50 years, we've come from trying to figure out what's wrong with the patient but not able to do anything about it, to now not only understanding the patient, but having all of these tools that allow us to examine the nervous system, whether it's developing or developed or degenerating later in life, and now intervening therapeutically with the expectation that we will protect the patient, either rescue the phenotype or prevent them from getting the disease. And I remind you, we have such diseases like phenylketonuria. When a baby's born with phenylketonuria, PKU, put them on a diet that has low phenylalanine, we can allow them to grow up as productive, normal citizens. And now, just recently with spinal muscular atrophy, if a baby's born with genetic spinal muscular atrophy, we can now give a treatment directly into their spine that will prevent them from getting spinal muscular atrophy. And I hope in the not too distant future, Glut1 deficiency will be the next condition where we will go from the standard of care with the ketogenic diet to a disease-modifying treatment that will truly protect the patient and allow them to enjoy all of their God-given opportunities to be successful as mature adults.